Hi everyone. Welcome to this webinar. My name is Wajin. I'm the President-elect of GNAPH, the Global Network for Academic Public Health. And now I'm representing Professor John Middleton here, and he's actually on the way, to this webinar. And so we got to start, the ball rolling. So what we have today is, the title From Data to Action and Global Burden of Disease and the Role of Academic Public Health. Welcome to all of you. A very good morning, good afternoon, or, good night, from my part of the world here. Now, it is indeed a privilege for us to have this webinar. And we have with us here two presenters who will be presenting later on. Professor Christopher Murray, who is the chair of the Department of Health Metrics and Sciences, UC of Washington. And also we have with us research training specialist, Emily Madison from the Institute of Health Metrics and Evaluation. And all of us, Professor Laura McDonough and myself, we will be the panelists for this session. Right, now, just some housekeeping here. You can ask any questions writing anytime during the webinar. You just got to simply click the Q&A button at the top of your screen, at the bottom of your screen, and type them into the pop-up box, all right? Yeah, and this webinar, it's now recording and will be available at the webinar event page on the GNAPH website soon. Right, so right now we have the speaker's presentation From Data to Action. Can we have the speakers then? Professor Christopher Murray.
Thank you. Let me share my slides. Hopefully you can see those. So it's a pleasure to be here. I am going to go through, as long as I can make the slides advance. There we go. I'm going to talk to you about what is the Global Burden of Disease study, what are the findings from the latest round of the GBD, which is GBD 2023, and then a couple of slides on ways you can engage in the future, in the future iterations of the GBD. So the GBD started back in 1991. So it's now 35 years running. And if you're interested in some of the history, there was a piece I wrote in Nature Medicine a few years back for the 30th anniversary of the start of the GBD. I like to think of the GBD, since it began, as rules-based evidence synthesis for global health. The first GBD study, initially sponsored by the World Bank, then WHO, was quite limited in scope, small number of diseases, about 100, a few risk factors, 5 age groups, and just for 8 regions. And now the latest iteration of the GBD is 375 diseases and injuries, about 88 risk factors for each country in the world. And for 20 countries, it's done at the subnational level. A key aspect to the GBD is that it is a large collaborative undertaking. We have more than 20,000 enrolled collaborators who've read the GBD study protocol and agreed to its governance. And you can see on this map that they're quite globally distributed. And the countries with more than 200 collaborators tend to be the ones where we have subnational burden of disease underway. In most cases. A key aspect of the GBD is the integration of many, many data sources. So GBD 2023 had about 325,000 data sources used, whether from published studies, surveys, administrative data, vital registration, disease registries, etc. They're all cataloged in something called the Global Health Data Exchange. So you can go and get the metadata and how to apply for data from different governments and different groups that hold data in the GHDX, the Global Health Data Exchange. It's a great research tool as well. A key aspect to the GBD since its beginning has been the use of online data visualizations. Our flagship data visualization, Emily is going to walk us through, is called GBD Compare. And there's many ways to interact with the data pretty much instantaneously. And coming sometime in the future, probably late in the fall, will be a chatbot interface that allows you to also use natural language to interact with the GBD database. Now, along the way, many statistical methods have been developed to deal with specific analytic challenges that emerge in sort of global health measurement. One I want to flag your attention to was introduced a few years ago called the burden of proof method. And this was in response to critiques of not the GBD in general, but just generally of diet epidemiology by John Ioannidis and others, arguing that the empirical basis for the relationships between diet and outcome in the GBD elsewhere were not as robust as, let's say, for smoking and lung cancer or heart disease. So over a number of years, we developed a method called the burden of proof method. In Nature Medicine, the sort of flagship methods paper, and then subsequently there's been 15 or more, and there's a stream of them in development, of using this approach to star rating the evidence on an association. So just to give you an example, you can go to the Burden of Proof website and see all the studies that are available on the relationship between, let's say, red meat and ischemic heart disease, and you can see how strong the relationship is and understand why we give that a 1 star out of 5 association, whereas for blood pressure and ischemic heart disease, we give a 5-star association. Again, a methods-driven approach. Now, the GBD collaboration produces lots and lots of papers. Last year, there was probably the biggest expansion. There's almost 3,000 papers in 1 year from the GBD in the peer-reviewed literature. And since GBD 2010, which is sort of when we made a major change in approach and methods, there's been almost 6,500 papers in the peer-reviewed literature. We've also been able to take advantage of AI models and send agents to investigate how the GBD gets used in different policy documents by governments. And so we've investigated the 205 countries we make estimates for and found about 7,500 documents from governments that make some use of the GBD. And then we've looked at both the types of uses using these AI models and then the types of topics covered by them. And you can see this description around the use, which is really quite broad across things that you might expect, like policy design, agenda setting, monitoring and accountability, and then implementation, resource allocation. And then you can see the sort of themes of these use, general health strategy for ministries, non-communicable diseases, and on down the list. So the GBD is a large collaborative undertaking. It's been around for 35 years. It's extensively used by governments as well as in academia. So what does it tell us, the key findings tell us? So this is one of the visualizations that I like very much from the GBD. It tells a simple visual story. This is a tree map where the totality of the rectangle is the number of disability adjusted life years, our apex measure of health loss in the GBD. So think of it as years of healthy life lost in 1990 by cause. And the blue boxes are the non-communicable diseases. The red-orange boxes are communicable maternal and neonatal causes, which are more characteristic of the poor. And then the green boxes are injuries. And in this tree map, you can see back in 1990, The largest contribution to burden in the world was the communicable maternal and neonatal causes, with prominent roles from diarrhea, lower respiratory infections, measles, malaria, neonatal causes as examples. But still, already in 1990, stroke and ischemic heart disease, big boxes on the bottom left. Now, go forward to 2023, and a lot has changed in the world. We've moved to a world where non-communicable diseases are predominant. There is still, at the global level, of course, this is highly varied by country, but still there's an important contribution from the communicable maternal and neonatal causes on the top right and from injuries on the bottom right. But notice on NCDs, big increase in the contribution from diabetes, from hearing loss, from visual impairment, from mental health disorders like depression and anxiety, as well as continued contributions from the cardiovascular diseases and cancers in the top left. So that's a disease view, and it's a view of the complexity of the number of diseases contributing to the world, to burden, as well as how it's the epidemiological transition is rapidly underway. A risk factor view shown here is where we look at each of the 88 risks, and this is the top ones at the global level, and ask the question, if you moved the world to the theoretical minimum risk level of exposure, how much would we reduce burden of disease? So this is population attributable burden. And in 2023, malnutrition is still the number one. It was number one back in 1990, but it's come down about 70%. So even though it's the largest risk factor, it's a huge reduction in attributable burden. And then we start to see some of the risk factors that are driving NCDs, like high blood pressure, air pollution, tobacco, and diet at the top. And notice that high blood sugar and high body mass index come in next. And those are going to be important when we think about the future, because those are rapidly increasing as exposures, and they're clearly linked through the mechanism of obesity leading to diabetes and high blood sugar. Now, a few things to call out in the GBD, because they have had important findings over the last 35 years. First, this diagram is showing the probability of death from birth to age 20. So instead of calling child mortality just deaths under age 5, because children, don't suddenly become adults at age 5. So we're looking here at the probability of death from birth to age 20, and stratified by World Bank income groups. So in low-income countries, back in 1990, that probability of death was about 23%, and it's down to about 10% today. So huge progress, but still very high. And contrast that with high-income countries, where there's been progress, but we have about a 1% probability of death between birth and age 20. So huge progress, even in low-income countries, but still the disparities are 10x in 2023 between low-income and high-income countries in this measure. And on the right-hand panel shows you where the probability of death is still 10% or more in the red colors, and it's the predominant role of the Sahel in high levels of child and adolescent mortality, the band in red from West Africa all the way over to Somalia. Second key observation in GBD is the enormous increase in the share of burden that is related to NCDs. So again, World Bank income groups on the left, and you can see high income countries, even back in 1990, dominated by NCDs. Then you can see the huge increase in upper middle income and lower middle income, green and purple, over the 35 years in the share that's due to NCDs. And even low income countries, we've seen this increase steadily rising as shown. And on the right-hand side is just the rank order of causes of burden in 1990 and 2023. And it's telling you the same story as the tree map told you earlier on, this big shift towards NCDs, the big rise of diabetes, COPD, low back pain as big causes of burden, and the big progress we've made in the world of reducing the burden from things like measles, malaria, TB, and diarrhea. Another key observation, one that has taken quite some time to confirm in the data, has been the rising share of burden and rates due to mental health disorders, particularly depression and anxiety. So the left-hand panel is the share of burden due to mental disorders. And it's going up in all regions. And, we observed this big surge during COVID, but the trend is much longer running. And there's a lot of controversy as to why. Is it social media? Is it, a view that the future prospects, because of challenges like climate or other things, is not as good, and this is playing on younger generations' mental health? Nobody really knows, but what we do know is that the burden is rising. And the right-hand panel just emphasizes that depression and anxiety are the big drivers of mental health burden. Another trend that we see in the data is rising numbers of deaths due to heat. This is showing high temperature related deaths, and this is not death rates, this is just counts on the left, just to be transparent, where we see about a doubling from 1990 to 2023 in the number of heat related deaths. And interestingly, on the right-hand panel, the heat largely affects NCDs in older age groups. So blue is the cardiovascular diseases and purple is chronic kidney disease. But it still also has an effect on pneumonias, particularly in red at younger ages. And then some of the injuries in green in the middle age groups. So very diverse effects across the age range from temperature. Another huge trend we see in the world is the enormous increase in the burden attributable to overweight and obesity. So both exposure to obesity is going up around the world, and the fraction of burden attributable to obesity is going up, as you can see in the left panel. And the remarkable thing about obesity and overweight is there is not one single country where the level of obesity is not increasing. So it's increasing absolutely everywhere. No success stories in bringing down obesity so far. And there are various claims that have come out at points that we've reached peak obesity, and then subsequently it turns out that that's not yet the case. We will wait and see if GLP-1s really have an effect in the high income world, but it's still not really clear in the data if they have a population level impact. But this is a huge global risk, and you can see that it's rising everywhere, even an increase in the low income world in light blue on the bottom left. Now, one of the things that I want to flag about the GBD is that it can be used, the curated data that we have on the GBD can be used to measure how well health systems are doing. One way to do this, building on the work of Martin McKee and Alan Nolte on the tradition of amenable mortality, is we've been calculating in the GBD a measure that's built up from a number of causes that are highly amenable to healthcare, an index called the Healthcare Access and Quality Index. And this just shows you the results for 2023. Basically, the idea here is that if you look at causes that are highly sensitive to healthcare, it gives you some insight into how effectively we're giving people access to quality care. And the HAQ, interestingly, in the statistical analyses, is the most predictive measure of health outcomes that we have, more than education or income and socioeconomic drivers like that. And it spans from a very low level in a number of countries in the Sahel, in the 20s on this index that goes from 0 to 100, up into places like Japan or Northern Europe or Australia, where it's in the 90s. So that's a very quick run through some of the empirical findings of the GBD. It is a global public good, and it's meant for you to use, to write papers from it, to use in teaching. And we'll talk about that. And I just want to give you a couple of slides about ways to engage on the GBD, and then Emily's going to walk you through the tools. We have a number of resources that you can go to and look up and use, both on how to use the tools, how to access the data, how to write papers from it, as shown here. And then just want to put a shout out to the GBD Fellowship, where we have started a fellowship program for advanced training in GBD methods. That is a 2-year program where people would come and to Seattle, to the Institute for Health Metrics and Evaluation, and both get trained and work hands-on different GBD areas. We had a great pool of applicants for this last year, and our first cohort is coming in September, and we will obviously continue this into the future. Now I'll pass over. Oh, one last thing here. I was able to create a prize for GBD emerging researchers, which we give out each year at the Rue Prize event in London in October. There's an independent prize committee that picks the winners from the applicants that come in. And so if you are somebody participating or innovating in this space, or know somebody, please nominate them for the future. So over to Emily.
Good morning, I'm Emily Madison, and I'm going to be walking you through one of our major tools that we make available publicly, which is a GBD Compare tool. You can access this on our website, healthdata.org. You can also search for it in any browser, Google GBD Compare, and it should be the first option. It's best on a laptop or larger screen versus a mobile device, and it will prompt you to sign in or register for an account before you can get started, but that just takes a minute or two. So the idea behind this tool is that we want to make exploring health trends and patterns using the latest GBD results as easy as possible. So in this case, this is our latest GBD 2023 results. And it's designed to really help you analyze, disease patterns over time, or comparing different risk factors, looking at a specific country and exploring age and sex patterns within that country, or even comparing countries, regions, or global trends across different causes, risk factors, and other measures that we produce. And so you could use this, Chris has given some great examples in his talk, and a lot of those figures come directly from this tool. And so I'm just going to walk through how you can use it yourself. So on the left-hand side, there's a control panel. And this is where almost all the options are. So in the far left are a series of pictures which represent the 11 different types of graphs that are available. So for example, we have maps, we have line graphs, we have a really interesting life expectancy decomposition figure, which we won't be going over today. I'm just going to go over 3 or 4 of these. Then in the settings options itself, you can choose which cause you're interested in, which measure you're interested in, whether that's DALYs or deaths or any of the other measures we produce. You can change the estimates by year. This is a selection of age groups, sexes, and then whether you would want to look at number, rate, or percent. There's also, within each figure, there might be some custom options. So in this case, you can look at subnational locations by adding more detail to the map. And then at the top here, there's this option for advanced settings. And all that does is allow you to access even more detail. So all of the causes are the same, all of the locations are the same, but you were able to access like a full suite of age groups, including age standardized results. And it also allows you to access the full suite of measures that we produce for, which include our summary measures, YLLs, YLDs, and DALYs, more classic measures like prevalence, incidence, and death, and then some of our mortality estimates, which include the maternal mortality ratio, probability of death, life expectancy, and HAIL. So there's a huge amount in this tool. There are also options to look at a map while looking at any of the other figures or comparing two figures side by side across any of the parameters that we estimate for. I'm not going to get into further detail there. And in the top right, we have a series of sort of global options. So in the help drop-down, we have more information about the tool. And I particularly draw attention to this bottom link, Get Training, which would lead you to about an hour-long online course, which will go through more of the options in more detail than I have time for right now. We also have the tool available in a variety of languages. So you could choose to change the tool into whichever language makes most sense for you. And then if you want to share what you're looking at, what's really nice is in the share dropdown, you can share links, and those are stable links to the exact figure that you're looking at. So it's not just a link to the website, but you can copy a link, and if you then paste that into your browser, it would take you to exactly the figure that you were just looking at. So a really nice way to share results with colleagues. You can also download a screenshot of any of the graphs that you're looking at. And if you want the underlying data, you can also download the data that's underlying the specific graph that you are looking at. And that will also provide a citation for those results. The GBD results tool allows you to access more of our results directly if you want to download them for your own research. And in the top right, we're really are not going to unfortunately have time to get into any of them, but just to highlight, this is not the only visualization we produce. So there's a whole suite of tools online. Chris brought up the burden of proof work. I think that's a really interesting one to look at. But we have quite a few. Financing global health is also a major one. So Chris already talked through what this tree map looks like. And if we look at DALYs globally, you can see in 2023, that was dominated by stroke, neonatal disorders, and IHD. And actually, IHD was the leading cause of health loss in 2023. If we wanted to look at that across countries, you can obviously go and look at the map option. And we could change the cause to ischemic heart disease and look at how that changes over time. Now, this is all age rate. For the epidemiologists in the room, you might be more interested in the age standardized rate. Another really nice option is we have made it really easy to create custom subnational maps. So you can use this location isolation to select particular locations you're interested in, which you can use in a variety of ways. But one of the more interesting things is if you increase that detail down to see the subnationals, and let's say we select Mexico, which I know has subnational estimates, you can actually get a state level map for any country with subnationals, which is really nice and quick, right? That's a lot of work a lot of the time. So this is kind of looking at the results across space. We could also compare causes against each other. So in this case, we are still looking at DALYs, age standardized across the world. We organize our results into these hierarchies where at the top we have noncommunicable group 1 and injuries. group 1 being communicable, maternal, neonatal, and nutritional disorders. And then as you go down, it increases in detail. So at level 3, that's where you're going to see ischemic heart disease, which in the age standardized space is beat out by neonatal disorders, since disorders that happen in younger life are going to weight more heavily in the DALY space. If you wanted to look at ischemic heart disease over time, you could look at a few of these different figures, but we could jump down to the line graph. So it automatically shows you about 20 select countries, but you could change that group. This is a good time actually to get into the location groups that we offer. So we offer a ton of custom groups. So if you wanted to look at the African Union regions, you could look at those. We also have WHO regions, the World Bank regions, as well as GBD super regions and regions, if you're familiar with those, as well as, every individual country and their subnational locations. Chris already showed this attributable risk figure. And again, like the causes, we have they're organized in a hierarchy where we have behavioral, metabolic, and environmental at the highest level, and they break down into further detail. So this is looking at all diseases, but if you were just interested in the risk factors for a specific disease, you can change those options on the right. So we've been looking at ischemic heart disease. I could look at ischemic heart disease here, and that would allow me to see the risk factors that we have established in a relationship with ischemic heart disease. So in this case, high blood pressure is the leading risk factor in the GBD for ischemic heart disease. So as I said, there's many more figures here that we're not going to get into today. I just want to highlight again those options for sharing links or downloading those estimates. And also just highlighting, we only looked at DALYs today, but there's actually, a really huge, basically all the GBD estimates are available here. So we've got, over 375 diseases and injuries. There's 88 risk factors. We even have etiologies, impairments, and other options that we didn't even touch on today. And also just highlighting that, there's many measures available in here. So that includes, life expectancy estimates, DALYs, prevalence, all of those. So really thank you for your time. If you have any questions, feel free to reach out to me now or afterwards. And as I said, there's great resources online if you want to learn how to use this tool more thoroughly. Thank you very much.
Wonderful. Well, thank you so much, Chris and Emily. This is fantastic. And I'm sure we could have been here for 3-4 more hours just learning the incredible power of your tool. So thank you so much for everything you do and for this incredible tool. My name is Laura Magaña. I am the president and CEO of ASPPH, but I'm also the founding president of GNAPH. So for us, it's incredibly important, this conversation. So thank you for your time. So my message right now is going to be about, my respond as an academic public health professional and how I see, the use of this incredible tool that I have been, fortunate enough to be engaged and with it and just play around and use it along all these years. But from an academic public health perspective, I think that the value of GBD is that it gives us a rigorous, globally comparable evidence that can strengthen not only research, but also teaching, priority setting, advocacy. So for schools and programs of public health, these tools help students understand real patterns of burden, risk, and inequity across populations and as well as over time. There's an opportunity for us to use these data much more deliberately in the classroom, in the health systems research as well, and in preparing really our graduates who can turn evidence into action. So for me, there are 4 or 5 highlights that I would just want to share with the audience. First of all, I think that GBD is a tool for academic public health, not just a reference database. So GBD provides systematic scientific estimates of health loss due to disease, injuries, and risk factors that they have been explained across age, sex, geography, time, and now draws on a very large global collaboration, making it especially valuable for schools and programs of public health that need common evidence to support teaching, research, and decision-making. But also a second point is that GBD helps make public health education more concrete and data-driven. So faculty can use GBD tools to help students move from like broad concepts to the real-world patterns, right? In mortality, disability, and risk. So the GBD compared option and other related tools allow users to explore really trends visually and also comparatively. Useful for teaching, of course, not just epidemiology, but also health systems, prevention, policy, and really many more. Number 3, I think that the 2023 findings reinforce what schools should be teaching now. The findings reveal persistent inequities, as we all know, right? The concentration of poor outcomes in places like we have heard, the Sahel region, a growing burden of non-communicable diseases, the rising mental health burden among young people, and the increasing importance of environmental risks such as heat, air pollution, and lead. So these trends point to the need for curricula that are cross-sectoral, life course-oriented, systems-based, and of course, globally informed. And number 4, academic public health can help translate data into action. So schools and programs can use GBD findings to train the students and researchers to identify priorities, to understand major risk factors, to question wherever resources are aligned with the need, and think more critically about implementation and prevention. So this is especially important as health systems confront both ongoing infectious diseases challenges and rapidly rising the NCD burdens. And finally, I think that GBD is useful for health systems thinking, not only disease tracking, but health systems thinking, right? So the analysis derived from GBD can help really assess the healthcare access and quality, universal health coverage, and how effectively health systems translate spending into healthier lives. So that makes GBD really relevant to academic public health, not only, again, for EPI, the classic classes, but also for all the classes, like a cross-cutting tool that we can all use. So I really encourage all of you to get used to it, try it, play with it, learn. It's going to take, a while to get to know all the tools. It's amazing the resources that we have available for all of us, for teaching and for research, and again, for also advocacy. So thank you again for being in this webinar. You're already showing your interest for the GBD. And again, thank you so much for all your work, Chris, Emily, and all your team. And with that, I'm going to pass it to Wayun. Thank you.
You're muted.
You're muted, Wayun.
Sorry. Yeah, I think this is really exciting, listening, Laura, and I couldn't agree with you more, that there's so, many benefits, in engaging with this GPT 2023 data. And, not only the points that you have given, but speaking on behalf of GNAPH, which is a academic public health organization, how we can actually use this data set, or the findings, that's been presented by Chris, and the methodology, given by, Emily itself. And so I think as an organization, academic public health organization, we could actually learn more, about this methodology, in a sense that, as you can see, GNAPH consists of 7 regional organizations in this whole world, globally. and between the regional organizations and within the organization itself, there is vast diversity. Yeah, between one region to another region, between one continent to another continent, and what more within the continent itself, between the countries, there's vast diversity. Diversity in terms of economy, in terms of health disparity, for instance, in terms of demography, epidemiology, and even politically. And so one of the things that I think, as far as future collaboration is concerned, for GNAPH itself, it's perhaps GNAPH could further engage or, further collaborate or strengthen, our collaboration with IHME and even with other world organizations as well, such as WHO or even World Bank. And as far as, for instance, highlighted in the findings, the effects of climate change and what have you on environmental health. And therefore, I think, it's important that we also work with United Nations, UNEP as well, with this. And if GNAPH could actually leverage on this data, I think that would be so wonderful. I think one of the point that Laura has mentioned is with regards to research collaboration. And I think this is where, the resources between one another from one region to another region, if we could share our resources, because in certain places, which is still developing, we may not have the resources. And this is where, other more advanced countries could actually come in and share those resources. And with the data, with the findings given by GTB 2023 data set, and this is where we can further, research into comparative analysis, for instance, what has been shown by Emily, the differences between the regions. And within the regions itself, the country specific and regional specific. I think this could be really marvelous in terms of, converting those data to help, our government in terms of policy per se. So I think these are some of the things that how GNAPH could actually come in. And the other thing is with regards to policy, not only informing our government, regional or within the country itself, and to make our policy, aligned, with the SDGs that we have. And the other one, most importantly, which I think, as far as GNAPH vision and mission is concerned, is to really build, our public health workforce capacity. Now that we can see, the epidemiological transition, from, communicable disease to NCDs, more research pertaining to NCDs, and therefore, with all these different health trends and what have you, and therefore, I think GNAPH, has an active role to play as far as creating more capacity in terms of public health workforce. So I think those are some of the things that, GNAPH could actually in terms of forward-looking and collaboration is concerned. I think those are some of the aspects that GNAPH could actually do. Right. Okay, so I think we are there now. So can we now move on to the Q&A from the floor?
Yes, and we have a couple questions that have come in. If you'd like to grab them from the Q&A. And also, John, I'm not sure if you wanted to try your microphone once to see if you'd like to be able to join this discussion. If not, he may not be able to. Okay, then let's go to the first question, which is, what was going on in low-income countries in 1994 to 1995 that accounts for that increase in child mortality?
That was the Rwandan genocide. So, some of these large events like the genocide in Rwanda, like the Haiti disaster in 2010, you can see them at the global level. because there are these spikes in mortality. COVID, of course, is another one that we see. But yes, that's the genocide in Rwanda.
Thank you. Appreciate the answer. The second question comes in, and this one is also for you, Chris. It says, I really appreciate the presentation, very informative. On the figure depicting impact of high temperatures on health, I was surprised to see that low-income settings had a much lower rate than lower middle-income countries, and wondered if you have a sense of why there's such a big difference, what factors could be influencing these trends, and do you think it might be a result of underreporting in low-income settings where there are weakened health systems and fragmented data systems?
Yeah, I did mention when I presented, but it was easy to miss in going through that particular figure was counts, not rates. And so what we were seeing on the low income world is just the smaller number of people living in them. The heat related death rate would be higher, for example, in the Sahel. But that was a picture on counts. Now, interestingly, I think there's a lot of interesting things going on the sort of heat-related side. I co-chair a commission, a Lancet commission on 21st century global threats to health with Natalia Kanem, who used to be the head of UNFPA. And we're just wrapping up, and hopefully we'll be releasing the report in the fall. And the idea there is to quantify what's avoidable or amenable to policy action across 17 major threats to the world. One, of course, which is climate. And so using the GBD database, using the forecasting platform that we really haven't spoken about much here, we have done a lot of scenario building on climate, for example. The interesting thing is the main impacts of climate change are likely to be the direct effects of heat and also on air pollution, and not the talked about effects on infectious diseases. I mean, there are some effects there, but the direct effects of heat and air pollution are much, much larger in the future. And likewise, storms turn out to not really be such a big issue. In fact, there may even be fewer storms if there's higher emissions. I mean, the climatologists have a very, very active debate right now. So there isn't a consensus about that. But the direct effects of temperature are the main part. And that's mostly on cardiovascular disease and chronic kidney disease. And there's an interesting interaction between climate and obesity, because the same diseases that are going to go up because of obesity are also going to be influenced by higher levels of temperature. So you see this sort of negative interaction, if you will, between the obesity epidemic and rising temperature.
So can I ask a question to Emily? Because I think that a lot of our audience are faculty, and maybe a lot of them, maybe this is the first time they are hearing about GBD. So would you recommend them where to start? There's so much that they can get from this, but is there an easy way to an entry points that you would recommend for faculty that are just starting to use the tool?
Yeah, absolutely. I think my colleague Sean can probably provide the link in the chat. We have a learning platform at GBD. So on our website, we have the GBD Learning Center, which provides links to trainings on GBD Compare, but also courses on more detail about introduction to the Global Burden of Disease study, how our measures and metrics are used and what they mean, and other resources, including our papers and things like that. So that's where I would start. And healthdata.org in general has got a great wealth of information on it.
Wonderful. Thank you. Thank you for that.
Thank you so much. We appreciate that. There was another question that's just come in, and it goes back to how frequently the Global Burden of Disease study is likely to be updated. The question is whether it's conducted yearly, which I imagine is not, because we're talking about the 2023 study, but when can we expect the next official release? How frequently do you revisit this data?
So the team working on the GBD is working on it continuously. It's not we don't stop. There's basically the 20,000 collaborators, and there's about 200 people in Seattle who are dedicated to working on the GBD in various forms. So it's a continuous revision process. The next generation will be GBD 2025. That should, we hope, come out before the end of this calendar year. That's the goal. It may slip into, early 2026, depending on the peer review process. Because remember, we have many layers of review on the GBD. We have our internal process across all the collaborators, and that's an extensive process. There's an independent oversight committee on the GBD called the Independent Advisory Committee on the GBD, chaired by Peter Piot, that meet every 6 months to review the methods and the approaches. And then, of course, there's the peer review process, which, is always a very, as all of you who are academics know, there's a variable aspect to peer review. You don't know how long it'll take and what will happen. So next version, hopefully end of the year. In general, because it's a continuous process of new data coming in, new analyses, commentary coming in from collaborators who want to change things or improve them or incorporate new data sets, and a very extensive methods development research program that runs in parallel. Sometimes when we have major methods changes and then we have to re-estimate the whole time series so that everything's always internally consistent, it takes time. So generally every 2 years is probably what it is, and a little bit sort of a function of some of the add-on projects that are occurring. So for example, another one that we've just participating in is another commission on health system performance assessment, chaired by Julio Frank and myself, which will then is already driving some further work on using the curated data of the GBD to see if we can disentangle how much is the contribution of health systems and how does that vary across place? How much is the contribution of environmental and other risk factors, which is there in the GBD, and how much is social determinants? And then can we, for each country, understand where they stand on those sort of 3 broad dimensions, if you will. And so I think those add-on or those extensions of the GBD work affect our timeline. GBD 2025, we have got a major development that we are trying to implement, which is capturing what's called dependent comorbidity. Right now, the GBD, we didn't talk about all the details, but we try to capture how much, when people have more than one condition, because that affects, it's an important issue for many health systems dealing with multimorbidity. And now we have our math sciences program has developed some interesting new methods that allow us for the first time computationally to bring in data on what is the probability of having more than one condition. Does my probability of having one condition influence my probability of another condition? Answer is yes, and that can be biological or that can be social. The poor have more of everything, sort of in general. And we will hopefully in GBD 2025 be able to implement this new set of methods. But that's an example of where there are a series of methodological innovations that have been underway for a number of years and eventually come to fruition. And then we take collectively the GBD Scientific Council, which is the governance of the GBD, take the decision, yes, we'll roll that out into the next iteration of the GBD. So there's there's sort of a pipeline, if you will, of both innovation and new data coming along that influences the timing.
Fantastic. Thank you for that comprehensive answer. We appreciate it. There is one more. I'm not sure if we have time, Moyun, for this last question. This seems to go to Emily's presentation. So it's specifically about using the GBD compare tool to calculate or estimate the total dailies for a given country. I think you were demonstrating some of this, but if you could just speak quickly to that estimation.
Absolutely. I can just quickly share in the tool itself. So we spoke in the demonstration about ischemic heart disease, but if you wanted all of the DALYs for a location, you would just use the total all causes option at the top. And if you were interested in number, you can select number. So for example, United States in 2023, if we hover over it, there were 123 million DALYs in that year.
Thank you so much.
Can I just ask very quickly, in 1 minute, maybe to Chris, a last message to the schools of public health? Because I think that beyond using data, which is already a great thing, where do you see the biggest opportunities for academic public health, in particular the schools of public health, really contributing or using or strengthening this work? What would be your last message to all of us?
Through the 35 years, the GBD, a lot of the most interesting ideas and innovations have come from people in the network of collaborators that have engaged and said, hey, I have an idea on something we can do on health systems, or some way we can have looking at observed over expected as a measure of sort of benchmarking, or volunteering to take on a challenging set of risks and doing the systematic reviews and the burden of proof. So, it comes from having such an active, large group of collaborators, all sorts of innovative ideas. It's the power of academia, which is who knows where the best ideas will come tomorrow. And we see that on a regular basis across the GBD. So I think just encourage people to get engaged. And if you have ideas about spin-offs, ways to do it better, we're a very welcoming community for that sort of idea on the sort of innovation research side. I think there's also just, especially as people may not, and we didn't really talk about it in this session, be as familiar with the forecasting platform, where you can develop scenarios and we're starting to see more and more groups in different countries say, hey, what would happen in India if we achieved the following target, and play that out as a scenario, because that becomes a very powerful tool for dialogue with politicians, we have found. Here's where you're likely to go. Here's where you could go if you adopted X, Y, or Z. So it is, I think there's lots of ways that people can build on what's there, not having to, rebuild all the infrastructure, but just, move farther into new ideas and new applications.
Wonderful. Thank you so much. So, Wayun, I think you need to close. We have just 1 minute.
Right. Okay, so thank you all, the panelists, and our audience all for this wonderful discussion that we have. And I think we all agree that, we can see the value of having these GPT 2030 data. And I think academic public health organizations, we have a responsibility of actually converting this data, the evidences, into education, into advocacy, into action, for instance, program and what have you. And I strongly believe, that the collaboration, between all of us, between the various stakeholders, academic researchers, governmental organizations, I think our collaboration is actually essential in addressing all the very complex health issues as we can see, from the findings of these data set. So let us all continue to work together, to ensure that evidence remains serve equity for all of us in this world. Thank you. Thank you all.
Thank you.
Thank you. Thank you.
Bye.